Well, welcome to our Facebook Live event talking about Graves' disease and thyroid eye disease. We'll be here to answer your questions and to let you know any expert opinions that we can offer. It's always a pleasure for me, Ray Douglas, to do this. It's a fun process, and I couldn't thank the Graves' Disease and Thyroid Foundation more for helping us to put these together and to reach out so many people who really need our help and hopefully can benefit from the forum today. So what I'd like to do would be to host any questions. You can type in your questions at any time. I'll get to them, and I will talk about each of those in detail as much as you like. You can also follow up with questions if you'd like. If you feel that you want a little bit more facts, I'll try to give you a very balanced approach. And I'd encourage you that if you want more information about, especially about any of the things that we're talking about, feel free to email us. We often have email ebooks available for sending to patients or for giving you much more information, or can refer you locally where you can get the best advice and care. And so we'd like to get started. We have several of the audience has already typed in some questions, and I'll probably start with those because I think that they offer a really nice area to begin with. So one of the questions really dealt with people being farsighted, nearsighted, or stigmatism, having contact lenses, and whether this really has anything to do with either Hashimoto's disease or Graves' disease. So I think it's first kind of important to talk about what is Hashimoto's disease and what is Graves' disease, because I think that the distinction often gets lost, but they're both autoimmune thyroid diseases. And what I think is really important to remember is that autoimmune thyroid diseases are 10 times more common than all the other thyroid diseases combined. I mean, all the other autoimmune diseases combined, excuse me. So autoimmune thyroid disease is incredibly common. It comes in two forms, typically. It will come in a more chronic form, but it also comes in Hashimoto's, which is a very acute form, causing a lot of hyperthyroidism and a lot of inflammation. That Hashimoto's, from what I do, I'm not an endocrinologist, but an ophthalmologist and orbit surgeon, Hashimoto's almost never causes eye disease. About 10% of any type of bulging of the eyes, and we'll talk about what's associated with the eye disease, but any of the eye issues are almost never associated with Hashimoto's. And that's good to know because a lot of people are worried about that they're in the back of their mind that they're going to develop all these changes, but almost never happens. Graves' disease is a bit different than Hashimoto's. It also has these autoantibodies that attack the thyroid and often produce hyperthyroidism. But Graves' disease happens in a much longer, protracted way. It occurs often over many months, even a year or more. And it's something that takes a long time for the thyroid to become normal, if either with medication or on its own, or even with surgery or radioactive iodine. There's lots of controversy of how to do that. But in Graves' disease, about half of the patients have some form of eye issues. These eye issues don't usually affect the vision. They don't cause you to have new glasses. They don't change your astigmatism. They don't cause you to be nearsighted or farsighted. But what they can do is, if it's really, really severe, it can decrease your vision and have a blur, a kind of a white out of the vision if you think about it. But that's very unusual. What it mostly causes is changes to the outside appearance and to the comfort and to pain. And we had a lot of questions about pain, and I'll get into this a little bit more. But what the Graves' disease affects is it affects the tissues around the eyes. The autoimmune disease itself attacks the skin, it attacks the fat, and it attacks the muscles all around the eye, not the eye or inside of the eye. And that's very different from other forms of like uveitis or other autoimmune diseases. But what it causes is the eyes to bulge, by expanding the fat behind the eye or expanding the muscles behind the eye. Both of those cause the eye to push out and become very prominent, and people look very intense. But it also causes the eyelids and the muscles in the eyelids to retract and to open up very, very widely, and people can't close their eyes very well. And a lot of our before and after pictures, really give a great demonstration of this. It also causes the fat in the cheeks, even in the jowl area and around the brow, to expand. And that expansion causes a very different appearance for patients. So a lot of what I do is trying to restore patients to their previous appearance. It's not cosmetic surgery, it's a reconstructive surgery, but it's done in an aesthetic way so that we can actually give patients their appearance back. But the Graves' disease also can cause pain, and this pain often goes a little bit underreported. It is something that, the pain is tough because the pain sometimes can be a pressure type pain, or it can be a pain due to dryness or issues associated with the eye itself. And the eye itself can be painful from dryness, and that's often what we want to do, is to increase the lubrication of the eye and decrease the pain. But there's also other things we can do for the pressure. I'm just going to ask if anyone is having any kind of technical difficulties with the video or the sound stopping and starting, whether there's any issues, just type in and let us know. I want to make sure everyone can hear and see me. But back to the pain. The orbital pain and pressure that's associated with this disease is unique. And I've had patients, many patients, who have been on narcotic type drugs for a long period of time and just couldn't relieve the pain. And we've just done a study, looking at orbital pain and using Botox to actually decompress some of the nerves. One of the nerves runs right behind the eye and comes out into the temple. And this nerve often gets pinched in Graves' disease from all the pressure and everything. And there's often spasm around that nerve. And we use a tiny bit of Botox to relieve that. We can also surgically decompress that nerve, but it requires a surgery. The Botox has been effective in about 80 or 90% of people, and it's often a great test to know whether the surgery will be effective. But anyone with pain of this disease should really think about having a good evaluation to get to the bottom of the pain. I think that most of my patients, I'd say 95% or more, we can largely relieve the pain associated with disease, either from the dryness of the disease, causing either by closing off the tear drains, or using plugs or artificial tears, or doing the proper eyelid surgery just to allow the eyelids to close. We can do that, typically very easily, or we can actually relieve the nerves that go through the orbit and surround the orbit. And the muscles around those contract, and with a little bit of Botox, this often can be very, very beneficial for patients. And so I think that one of the questions was it's contact lenses and Hashimotos and Graves, and that's why I wanted to spend just a little bit of time talking about the distinction between Graves and Hashimotos, letting people know that this disease typically doesn't affect their eyesight per se, that it can affect it if it gets very, very severe, but not as far as glasses and astigmatism, things like that. That's typically due to, unfortunately, aging. Can make you a little more nearsighted, usually right around in the mid-40s, and certainly, other causes, but it's not just easily attributable to the Graves. So I think that's at least a good start for us. I'd like to pose another question, and again ask anyone else who they would like to come in to this discussion. So someone wrote in about, and it had a very complicated history, and I always like to be very respectful of names, so I'll give an overview of the history, and I'm not going to, I'll try to give things in general as much as possible. But a patient had 12 weeks of infusions, radiation sessions, decompressions, muscle alignment, lid retraction, and that kind of highlights what happens in this disease. One is the inflammation that's associated with this disease often requires infusions of steroids. I tend to try not to use steroids as much as possible because largely they've been shown to be relatively ineffective in this disease. Thank you, Angela. I know you post on Facebook, but I always like to be respectful. So Angela wrote in with this question. And then also, why you have bilateral orbital decompression. And that's to move the eyes back, take away some of the pressure, and then the muscle alignment that's often either associated with the decompression or the disease itself, and you have to realign the eye. And I have a prop here, and we can show that in just a little bit. But, one of the things that she was talking about was having constant pain in the portion of the eyes and, extreme eye pain. And, are there other ways to manage this constant pain? And I've had many patients actually. There's a video on my website about a patient who is very close, who had constant pain. I saw 10 different doctors, but this pain was largely, we had to break it down as to the causes of this pain. And her pain, and I think Angela's might be, I'm not going to try to diagnose this over Facebook, but the pain usually comes from a couple different reasons. One is that the pain can come from, again, the protection of the eye. And we take high-speed video often of people blinking. And normally when you blink, you do it very quickly. But in Graves' disease, there's tremendous scarring and also some paralysis. So it's like being encased in trying to run a marathon in a pool of water. So you can't run as fast, you can't move as fast. And that's kind of what your eyelid is doing. It's almost encased in scar tissue. What that means is that there's constant corneal irritation from that. And I've been fortunate to work with several optometrists who use PROS lenses. And in many patients, I've gone to using a PROS lens. And people can Google it. It's an external lens that protects the eye and constantly soothes and coats it in fluid. It's not a perfect solution, but for people who have constant pain, fluctuations and variations in their vision due to that pain and due to the dryness, it can be a lifesaver. And so that is one option. When the pain comes from the eye itself, from the dryness of the eye, from the irritation, from the failure of the eyelids to properly blink and to close, then that's one very, very good option. The other is the orbit pain. Sometimes there's just a background of inflammation, and you can try steroids, and there's scar tissue and things like that. But decompressing the nerves, the two nerves that exit the orbit, have been very effective in relieving a lot of pain from most of these patients that I've experienced. And it's always worth a try. It's not we're going to publish that study very soon. It's not an orthodox way of thinking about it. But the concept has been used quite a bit in migraine management. And migraine sufferers know that sometimes the only thing that relieves their pain is Botox to actually relieve some of the spasm that's associated with this pain. The pain associated with Graves' disease, again, is not very well treated with narcotics and things like that. But if the pain is associated with going outside, if it's associated with sunlight, anything that makes you light sensitive, going outside, things like that are very much associated with the outside of the eye and the dryness that's associated with it. So that's the first place to start, and to keep working through the solutions, always looking at the cause of what's going on here. So is that a question? How do you find out if your eye problems are thyroid related? Well, I should ask you just to fill in a little bit more to know whether eye problems, as far as what you mean by eye problems. Thyroid related eye problems are typically swelling around the eyes. The eyelids open up much more. The eyes become very sensitive and dry, and you're squinting all the time. I always say that it's kind of the thyroid squint, because you're really protecting your eyes and squinting them down, but you can't quite close them. But if your eyelids seem to be very wide open, a little bit of white showing under your eyes called scleral show, always having a very wide open eyelid look. And if you had thyroid, or even if you didn't have a thyroid related disorder, 10% of eye issues can occur without having a known thyroid disorder. So if you see these changes in and around the eye, that's certainly something to consider. And so I think that having those changes and those types of eye problems are very suggestive of a thyroid disorder. One of the things to look for is that everyone looks for eyelid retraction. Eyelid retraction is when the eyelid comes up, but it's lateral flare. It's when the outside of the eye lifts up very high. And that's something that you want to, that's very telltale of thyroid eye disease. And if you're worried about eye issues associated with the thyroid, I would see first an ophthalmologist. Because what they'll do is ophthalmologists are very accustomed to looking at the proper position of eyelids. Why some people have heavy eyelids, not heavy eyelids. But it has to fit the face, and it has to be what it looked like before. If there are major changes, then the ophthalmologist can, either get to the bottom of what eye issues are going on, or they can certainly even send the labs themselves. I often check a TSH for patients and help to manage them and get them, involved with an endocrinologist if need be. It's often hard sometimes to just show up in an endocrinologist's office and ask them the eye problems. Usually, if you're having eye issues, it's best to start with an ophthalmologist, and then you can kind of get referred as you come along. Angela wrote in that that she has the lower tier plugs, and that the lower tier plugs I do like. I actually like cauterization of the lower tier punctum if it's done correctly and lightly. Most of my patients find it much more helpful than plugs which can fall out or you can have a reaction to. So I think that I think it's careful. You just want to consult your ophthalmologist as far as what's best for you. So read that as an orbital decompression about 10 years ago, and her right eye is still bulging and the white is still showing. And is there anything that can be corrected? Absolutely. I'd say 80 to 90% of the patients whom I see for a consult have had previous surgery. The decompressions, and we'll get into this, and maybe I should show the model now. It's like, decompression is like buying a car. There are 100 different cars you can buy. And if you say that, I bought a car, well, is that car going to be able to carry your sofa home? And if you bought a two-seater convertible, the answer is no. And it's a different type of car than what you need to carry your sofa. If you bought a truck, pickup truck, perfect. But just as everything in life, is kind of variable, decompressions are variable. I've seen decompressions where it's kind of hard to determine how much the patient's had. There are lots of philosophies in thinking about decompressions. So absolutely, if the eye is still bulging, there's a lot of things you can do. I always focus upon a decompression of completely customizing it for every patient, and I try to reduce or eliminate the need for eyelid surgery by moving the eye around. And so, one of the things you'll talk about with your surgeon is how can you customize your surgery, what else can be done. And again, maybe the risk and benefit isn't there, but you would want to know at least the risk and benefit of doing more surgery. Often you can do more surgery with a relatively low risk, and we can talk about those risk factors if people are interested as to why some people can get double vision after and some people just likely won't. I do want to show you the picture here. So this is a little bit about what happens in thyroid eye disease. This is just a model, and this is the orbit and the bone around, and just slide this back a little bit. I think you can still see it. And what happens in thyroid eye disease is the muscles here that can move and control the eye, they get big. And the eye rides on a cushion of fat shown by the little cotton balls here, and normally there's a bone that wraps around. And this is the bone right here that you feel when you press all around your eye. When we do a decompression, we can remove a little bit of the fat from behind the eye and tease that out. It's a very safe procedure, often can be done in about 30 minutes and go home. I can also shave down the bone right back here, and that seems like that would be a tough thing to get, but it's actually just through an eyelid crease incision. Patients come in, go home the same day, and you can really move the eye back. And then the other form is that you can come to the other side toward the nose and push in the sinuses. Pushing in the sinuses or doing it endoscopically tends to carry the highest risk associated with the disease, and as far as double vision, and because that often tends to move the eye in various directions. And so I take the bone wherever it needs to be taken to move the eye in any direction. And so I think that that's often a very useful thing to do. If anyone ever wants, we have a thyroid eye disease booklet, that goes over all these concepts, and it's not about us, it's about just kind of so you have information about the disease, and we can electronically mail that to you too, so that you understand the idea of what is a decompression, why do people have it, and such. But at least this kind of anatomic example of what the orbit can look like, and usually I have people hold this model and we kind of look at it together and then come up with the solution. But absolutely, if you had a decompression 10 years ago, the techniques have totally changed. They're very different on the East Coast versus the West Coast too, but 10 years ago is a lifetime in this disease. Everything is done much more minimally invasive. The incision should be either, in many cases I don't use a skin incision at all, especially in Asian patients or African American patients where we can see the incision line. If not, it's hidden in the eyelid crease, and I have some pretty hidden eyelid creases, and most people never know that it existed. And you can't feel any bony issues on the outside. It doesn't feel any different, but it does move the eye back to exactly where we want it to go and to be able to improve things, certainly. Okay. So the question was, sorry, I don't want to miss any. So one of the questions by Rachel was, how soon after eyelid surgery will you know if the eyelid is still retracted? It depends on whether it's upper lid or lower lid, but the upper lid retraction, which is the most common when the eyelid and the upper eyelid is pulled way up, that is a surgery you do either from the outside through the skin or from the undersurface of the eyelid. It's technical reasons why you do it, different ways, one versus the other. They're both very effective. But you should have almost an immediate result with that. I have had cases, in probably 20%, 25%, where after a couple months, the eyelid will start off at a perfect height and gradually open, because what happens in Graves' disease is that the scarring process is much more severe and it can gradually scar back, and sometimes we have to repeat the surgery, and so sometimes that's an unfortunate event. But you should know very soon, right after the surgery, whether the eyelid retraction has been effective or not. The lower eyelid surgery, I've done less and less because I do a customized decompression surgery, so I'd say only 5% of my patients. I've eliminated probably 90% of the lower eyelid, the need for another lower eyelid surgery, and we can usually accomplish everything in one surgery. But when I do have to do lower eyelid surgery, it really depends upon how big the cheek is, what's causing the lower eyelid surgery. Sometimes it's after strabismus, sometimes there's scar tissue. So sometimes I have to build up the cheek to lift the lower eyelid, and sometimes I have to use a hard palate graft, or if it's just mild, I can usually cut away some of the scar tissue, and I use a lot of anti-scarring agents such as 5-fluorouracil that really inhibit the rescarring of this process. The other thing that someone mentioned, are fillers safe in this disease? They are, at least certain fillers in my opinion. I use fillers a lot in this disease as a non-surgical way of managing the disease. So I can lower the eyelids. I've had many patients who have had a daughter's wedding coming up, and it's 2 months before the wedding. They don't want to have surgery because the surgery, they could have swelling, they could have bruising, and they don't want to deal with that right now. So we'll often use fillers. Fillers can last about a year, year and a half, especially the hyaluron type fillers, which is the only thing I use in this disease. And we can lower the eyelid, and we have lots of photos of doing just that. We can also raise the lower eyelid up a little bit sometimes with fillers. There's limits to what you can achieve without getting an unnatural result, but most of the time you can achieve something that looks very, very nice, lasts about a year and a half, and sometimes then has to be, you have to go forward with surgery after that too. But fillers can be very safe as long as they're higher on-end fillers. I tend not to use other types of more permanent fillers in autoimmune diseases. The other fillers tend to cause an immune reaction, much more so, and so I think that it's a little riskier to use something that kind of sparks an immune reaction, and so I think you have to be a little bit more careful. I also, in other patients with other autoimmune diseases, if other people are really, really concerned about it, I'll do a little test behind the ear, and just to see if, is that something that bothers someone? Is that something that causes a lot of inflammation or reaction in some way to the filler? And typically it doesn't. Typically that's a very good way of actually, testing out and seeing how well this works. So that's something to bear in mind, that fillers are even another non-surgical option. I often lecture on this and give a small lecture of just all the things that you can do with filler for this disease. So I'm just going to we had a question about retina and a bleed in the retina, and whether this could be in any way related to the hypothyroidism. Probably not, at least directly. Hypothyroidism typically wouldn't cause a retinal bleed, or some type of an issue. It wouldn't at least be the first thought. There'd probably be, and it would be something to certainly see a very good retina specialist to get to the bottom of it, but chances are it may not be associated with the hypothyroidism. Hyperthyroidism, if left unchecked or if people don't take care of it, can lead to certain cardiovascular issues that then eventually could cause changes in the eye, or bleeding, or diabetes, related changes that look like hypertension. But it wouldn't be the first thought in this process. So it can't say absolutely no, but it'd be very unlikely, and you should really look for some other causes long before thinking that it's going to be that. So, and another question. So question was, so a lot of people ask me about homeopathic medications, especially with the practice here in Los Angeles. I think more and more so. Is there anything natural that people can do? Is there anything in improvement? And I usually refer them to an endocrinologist, and I think an endocrinologist who has your same idea of if you have a thyroid problem, how can you best treat it? And many endocrinologists are willing, as long as the thyroid functions are not harmful in any way, are willing to treat in a homeopathic or conservative way. I have many patients who will use probiotic forms of treatment to actually try to improve things. There is some cross-reaction probably with the glutens and other things that can actually cause issues and can probably aggravate this disease. So I've had many patients who've gone to a gluten-free diet and have noticed substantial improvements. I've had a few patients, even from around the country, and referrals from other physicians, where they've gone to a non-meat diet and had substantial improvement also. So I think that it's one of those things that it might require a little bit of trial and error for yourself to determine what actually works the best, and whether this may or may not be causing the thyroid issues. Most people can't use these exclusively. So one of the things that is tough is that often these homeopathic medicines may or may not work without using some type of bridge with medical therapy or surgical therapy or something. And you want to make sure that you're very careful in monitoring your levels, because levels that are either too low for a long period of time or too high for a long period of time can have some very severe long-term consequences. So you want to be very careful about that. I work with a group of endocrinologists and thyroid surgeons, and really my job is not to tell you how to manage that. My job is to put you in touch with endocrinologists, with whomever you feel most comfortable with in managing this condition. And for many people, that's a medical management, taking methimazole or some type of medical management. For other people, it's wanting this to be over as quickly as possible. And if they don't have any eye disease or any eye issues at all, I think radioactive iodine is reasonable. If they have moderate or severe eye changes and they need control of their thyroid, because it just can't be controlled in any other way, thyroid surgery is a very real option. We just published a paper in JAMA detailing that thyroid surgery probably diminishes the effect of having the eye disease. It probably diminishes the likelihood that people will get the eye disease as opposed to medical therapy and other therapies. This was taken from a large database. We have no information on homeopathic therapies and such. But so thyroidectomy, if done well, is a very safe procedure. You'd want to certainly have a thyroid surgeon who does a lot of these procedures. In a future Facebook Live event, what we'd like to do is have one of our preeminent thyroid surgeons come and kind of give a little bit of an overview of what this is, in addition to any endocrinologist talking a little bit about this management in general also, so that you can get a flavor of different viewpoints, and even save those videos for as you think about your own management for the thyroid issues. But thyroidectomy can often be done through a very small hidden incisions, and is again a very relatively fast, safe procedure to do, and may diminish the effects of this disease. Once the thyroid is controlled, many patients will opt to try homeopathic therapies, and have, as I said, achieved good results. So there's no timeline of actually dealing with the eyes as long as there's not a vision compromise. As long as the vision is not declining, there's no problem in actually taking a very thoughtful, stepwise approach to the treatment of the eye disease. Many people often ask me, and I have a question, as far as what are the chances that this disease will come back? What are the chances that that this disease will reappear during their lifetime? And the chances is about a 4% lifetime risk. And so and so that's actually rather small, but it is something that it's something that is small, but it's much higher in smokers. And in a smoker, that is something that you'd want to be very careful about. The disease acts much differently. So if there's any word of advice or anything that I can offer, it's that to not start smoking, and if you are smoking and have this disease, to stop. The therapy that's associated with the disease is much less effective if you're smoking, and it's much more of a severe disease, and it lasts much longer. So all those are unfortunately pretty bad. There's evidence of smoking, of even using smokeless tobacco is less. Secondhand smoke is less. The data on marijuana and such is a little unclear, but probably the generation of smoke does also have a negative impact upon the disease. That one's a little less clear. It's not sure how that really does affect the disease as far as studies and trials yet. But certainly there's no doubt that tobacco use and smoke in general does have a bad effect upon this disease. So I think that anything you can do would be very good as far as that is concerned. I kind of lost my feed for questions, but I think that we're doing pretty well. One thing that I mentioned earlier and that we talked about is vision changes. And one thing I'll show you just on the model, just in the is why you would get vision changes. And it's a nice sunny day here in Los Angeles, so the sun is shining in. And what you can see back here is this little plastic tube, which is simulating the optic nerve, is kind of encased around muscles and behind the eye. And when we talk about vision loss in this disease, we talk about these muscles getting so big that they squeeze the blood supply to this nerve that feeds the eye. And that's the major worry of vision changing, of vision in this disease, of how it affects people, how it may change their vision. So that's certainly something to always be consider and to consider in this process. So one of the other questions that often comes up is, why did I get this disease? And the real issue is that we just don't know. It's a change that often people can associate with some stress in their life event. There was a study that looked at that and didn't find it, but I actually don't believe that. I think that so many of my patients recall a life event that really just talks about this process, whether it's a passing of a family member or something that was very stressful. And we know from neuroimmunology that the immune system is intimately related, to the nerves and to the psyche of the brain as far as controlling the immune response. And so I think that there's no doubt that is. Some people are much more likely to get autoimmune diseases than others. And the chance that when you have Graves' disease, you are more likely than someone else in the population to have another autoimmune disease. So it's certainly something that you want to watch out for. Have a routine physical exam, be aware of the signs, of diabetes, of skin changes, of other things that can be associated with the disease, so that that you actually realize and understand what may be part of this disease process, because people are more likely. Also more likely to run into families. I did a large study in Denmark where we looked at all the twins in the state of Denmark, so to speak, in the country of Denmark, and found that the disease was related, about 30%, in twins, but that the disease also had a marker, the marker that we're trying to currently target in this prevention or cure this disease, that happened sometime after birth. So while genetics plays a role, it also means that 70% of the chances occur sometime after birth, and we just don't know what that is, the environmental risk, so to speak. And I'm not sure that you can prevent that, but certainly smoking and other things like that does diminish it. We had a question about the eye pressure, and that sometimes the eye pressure is in the 20s, but in the past it was 30 and 23, and why it's going up and down. And so one of the things in Graves' disease can cause changes in eye pressure. So it does it in a couple of different ways. One is that the way people take eye pressure is that you sit into a little slit lamp or something, or they blow an air puff onto the eye, and the muscles sometimes in Graves' disease are so tight that they actually prevent you from looking up, but they're so tight that when you sit into this little contraption, it places the eyes in a position that they're not accustomed to, and the pressure goes up. Even just looking up a little bit can dramatically raise the pressure inside the eye for patients who have this disease. So one time, you can be sitting at the same slit lamp, and I can just have someone change their chin or look up or down, and their eye pressure might go up 5 or 10 points. So the first thing is to make sure that your pressure is being taken accurately, and if you always sit with your chin up just a little bit, or if you have trouble looking up, your pressure may be going up artificially, and it just may be kind of an error. Graves' disease in general, especially more the moderate to severe type, increases the pressure at baseline about 2 to 3 millimeters of mercury, about 2 to 3 points. So it doesn't necessarily make it yo-yo, the tight muscle and the ability, and because you're trying so hard, you're kind of squeezing the eyeball to look up, or to actually just to look straight sometimes in this eye measuring device, can make it yo-yo, but the Graves' disease itself can make it a little bit higher, usually a couple points higher. Graves' disease, though, you want to make sure that there's no changes due to glaucoma. So the pressure is one aspect, but the next aspect is to really see whether there's any changes of the nerve that would be suggestive of glaucoma, or that there's any cupping, or if there's anything else. And that would be where an ophthalmologist would want to look into the back of the eye, into the optic nerve, make sure that there's nothing else that looks like glaucoma that would be worrisome. Because sometimes pressure can go up and down in glaucoma in addition to Graves' disease, but the two can be a little confusing to sort out, but your ophthalmologist can certainly help with that. But it does sound suspicious for Graves', kind of an artificially elevated pressure, but certainly want to check that out. And to check out, make sure that the pressure is the same on both sides or different on both sides. Sometimes when one muscle is tight, it just raises pressure in one side and not the other side. So it's certainly something to look out for. So we had a question, is it safe to ice your eyes on days when the bulging is bad? Good question. Absolutely. There's, in fact, there's an old trick in Los Angeles where, people would put their entire face into a bucket of ice water just to get all the swelling and bulging to go down. Absolutely. The things to work on the days when your bulging is bad is to think about what you did the night before. Usually salt intake has a tremendous effect upon eye bulging and bags. It'll make the fluid accumulate more because water follows salt, and it'll make the bags appear worse. So try to watch your salt intake. When you get up, because you're sleeping horizontally, all the fluid in your body kind of equilibrates. Then when you stand up all day, the fluid goes from your face down into your ankles. So the bulging tends to get a little bit better as the day goes on. So what you can do to help with that is that you can sleep at a little bit of an incline. Just a little bit of your head above your heart will help to improve that bulging that you can see day to day. The final thing that you can do sometimes to help is that if you get bulging or bags under the eyes, a lot of people get this, or they'll get the bulging over here. And it's often not fat that should be removed surgically, because people have had bad surgical results for trying to remove this surgically. But what it is it's something that you should do with fluid. And the fluid itself is what needs to be altered. And you can do that. You can try to camouflage it. You can use ice. But a lot of times I recommend foam tape. And you can take a little piece of foam tape. It's 3M foam tape. You can obtain it at a drugstore. It's not anything fancy. But it's stretchy. And so when you pull it, it stretches, and it actually has it's about 1/8 of an inch in its foam. And we can always, give if you email us or contact us, we can give you the exact name brand. But it's just 3M foam tape. It's about 1 inch wide. And you take that foam tape with a little bit of stretch, and you just put it under the eyes at night. It's not the greatest, looking thing as you go to sleep at night. But what it does is it tamponades or pushes that sponge. It prevents that sponge from accumulating fluid while you sleep at night, and makes it so that you don't get these bags as badly in the morning. And it can, I think, over time, I've had patients using this for years, and they get some very good results. Over time, what it does is I think it just prevents the tissue from stretching out too. So I think long term it does improve things. The good thing is that even a little fat decompression or something can improve the congestion that causes this bulging or fluid accumulation. But also the fluid accumulation and the bulging, the variability, tends to get a little bit better, but it takes a few years. It takes a long time for that to really even out and to improve over time. Some people are just more susceptible to it than others, but salt, raising the head, and foam tape work really well to try to prevent that. And again, it's not an easy surgery, so don't rush out to your local cosmetic surgeon and tell them to take away that little bit of fat. It's not, it'll make the eyes probably look worse, or even the eyelid retraction. It's not so much fat usually. Usually it's fluid and has to be kind of dealt with in a slightly different way. Usually moving the eyes back helps to take away some of the congestion and fluid. a lot of people get congestion around the eyes, and I mean that by, they get fluid around the eyes, their eyes are red, they're injected. And it's kind of like what I always say, if you put a rubber band around your wrist and you tie it really tightly, eventually your wrist and your hand is going to get very red and it's going to get very swollen. And that's kind of from putting in so much from the expansion of the fat and the muscle behind the eyes. That's often what happens during this disease, is it's kind of like constricting that blood flow and making it very congested and make it difficult for that blood flow to actually exit. And it often leads to this congestive disease. Making a little bit more room behind the eyes often makes a huge difference in this process, more than you would expect just from the amount of moving of the eyes back, but rather improving the congestion. So just something to think about and how to improve what you do. Well, we're beginning to come closer to the end of the Facebook Live event. One of the final questions was I'm still happy to take more questions. One of the questions was, well, how, if someone has severe eye disease, how do you determine this, and how do you start the process? Because everyone, I think, is very concerned that they're going to go blind. And almost no one should ever go blind from this disease, and it's very rare. But when you have a severe case of this disease, it often is when the thyroid is pretty severe and hard to control, and the eyes are bulging, they're congested, they're red, they're retracted, pain all the time, double vision. And if you notice any changes of the vision, especially of the color vision and of the clarity of the vision, but also the brightness, it's certainly something you need to look at, to really, really investigate. Asian patients tend to be a little more subtle, so a lot of times, I have a large Asian practice. We have a practice in Shanghai and also here in Los Angeles. But a lot of patients, Asian patients, tend not to have disease that looks bad, but can actually have vision-threatening disease. Patients with small cheekbones who are Caucasian tend to have a pretty obvious form of this disease. Younger people tend to also have an obvious form of the disease because there's a lot of bulging. But sometimes it doesn't come with a lot of bulging. It can be very severe. And so testing your vision, making sure that the vision is roughly equal on both sides, and you're not one of those rare people where this affects the vision tremendously, is a good idea. And as long as it's not a severe case like that, again, it shouldn't affect your glasses or other things. But if it is severe, a lot of times it's very difficult to treat. And a lot of people who I think follow this forum have had more severe cases of this disease. I'm always a little reticent to use radioactive iodine in any case that's moderate or severe because it makes the eye disease a little bit worse. There have been many studies that have shown that. But I think that really prompt control of thyroid management is critical. And sometimes I'll use steroids, but I tend not to use them long term. Sometimes I use rituximab or even radiation, but it has to be a customized treatment. I'm not a fan of giving long-term IV steroid doses and steroid infusions, because that can lead to a whole host of complications. And I think that now we have actually some things that are a little bit better and at least preventing some of the complications from occurring. So I think that really has to be if you have a severe case, a very coordinated care directed by your an oculoplastic orbital surgeon who knows about thyroid eye disease, your ophthalmologist and endocrinologist, really helping you to make these informed decisions, because there isn't a cookie cutter here for most people. There are pros and there are good things and there are bad things about how to deal with certain aspects of this disease and how effective they are, and they kind of have to be individualized a little bit, just because some people respond very differently to some of these interventions. And so I think you have to be very careful. For example, I wouldn't I don't start IV steroids on someone who has a history of heart disease and a little bit of diabetes. I know that I'll push them into being an insulin-dependent diabetic. So and so the same with radioactive iodine. If they have moderate or to severe disease and a large thyroid, I would tend not to recommend radioactive iodine, just because I know that it will make the eye disease worse unless there's a good reason to do so. So I think that's just something you always have to bear in mind, is that your individual circumstance may be very different. And Angela wrote, how can I find out more about the pros lenses? So there's actually several people in the nation who do pros lenses. It's called the Boston lens. It's not just in Boston, it's just called that. There are pros lenses people who are expertly trained to do the fit of these lenses. I've worked with the people that in Los Angeles and also at the University of Michigan, where I just departed. But you can work with your local area, and certainly if you email us, or we can help. But if you go online to the Boston Lens or Pros Lens, there's about scattered throughout the major cities, but usually there's just one, maybe two people in a large city. So it is something that's a little bit more unusual, so that's why I wanted to mention it. But in people who really just having a terrible time with this disease, it's at least worth investigating and giving it a try. And there's ways you can trial this to see whether that will help you or not. But it is certainly something that's worth trying. Also, having an evaluation to see if you can't reduce the scar tissue, the eyelids, improve closure. Those are really great ways to start. I've even had some people use serum tears, tear drops made from their own blood. That can also be very, very helpful for some patients. So there are the easy things to do, and then there's like 10 other things that are more advanced. And the most important thing is not to give up, because there's always something else to try or to move forward with, to not give up or to throw in the towel, so to speak. So we're going to kind of wrap things up at this point. I want to thank everyone, and again, I really want to thank the Graves' Disease and Thyroid Foundation, for helping us to reach out to patients. Certainly my staff, in Los Angeles, who've been, wonderful, of also trying to help us reach out. And I think that, if there's anyone who has questions, needs some direction as far as where they can seek treatment, we're happy to help. The form on the Graves' Disease Foundation certainly helps to direct events. Our local area, we putting together this type of a forum to have for patient education and support group, and we do that on a quarterly basis here in Los Angeles, but many other cities also do that, and the Graves' Disease Foundation has been incredibly supportive of those types of projects to help to reach out on a very individual basis, but also allow patients to actually talk to each other, understand how this really affects their family and not just themselves, how to deal with those things so much better. And so I think that reaching out to those resources, and certainly I'm very appreciative that they're here to help to coordinate these types of events and to move things forward. But thank you all, and I hope you have a very great day.